Welcome to the deep dive. Today we're really going deep, aiming for, well, absolute mastery over the surgical anatomy of the thyroid and parathyroid glands.
Yeah, and this isn't just, a casual review. We're digging into expert surgical texts.
Exactly. We want to understand why these operations demand what the sources call obsessive attention to detail.
And they really do. It's not an exaggeration. When you're working in the central neck, it's incredibly high-stakes real estate. We're talking millimeters separating a cure from, well, a life-altering disability.
It makes sense why someone like William Halsted called thyroidectomy the supreme triumph of the surgeon's art.
That quote, yeah, it really captures the difficulty, the nuance involved. It's perceived as one of the trickiest procedures for a reason.
And for you listening, I think the first fundamental point we need to get across is this core overlap. You can't really touch one without affecting the other, can you?
That's exactly right. They're so intimately connected anatomically. Any thyroid operation is, by definition, a parathyroid operation, too. And, vice versa.
So you're juggling thyroid function, which is crucial.
And parathyroid function, which manages calcium. That's literally life-sustaining. You absolutely have to negotiate both at the same time.
Okay, let's hit the biggest hurdle right away. The sources say the main barrier isn't learning the standard textbook anatomy, the in situ stuff.
No, not at all.
It's dealing with the operative anatomy. Why does it change so much once the surgery actually starts?
Well, it's a distortion, but it's one the surgeon deliberately creates, mostly. You've got two main factors. First, the disease itself, a huge goiter or maybe cancer, scar tissue.
Right, that messes everything up.
It pulls everything out of whack. The trachea, nerves, everything gets displaced, stuck together. But second, this is key just to see anything properly, the surgeon has to physically rotate the thyroid gland out of its normal spot.
Rotate it. How much?
We're talking about 120 degrees approximately. Pulled anteromedially, so forwards and towards the midline, just to expose the critical things behind it, like the recurrent laryngeal nerve, which normally sits kind of tucked away posteromedially.
Wow. So the second the surgeon starts maneuvering the gland, that textbook picture is basically useless.
Pretty much, yeah. You're navigating a totally new landscape that's been pulled and stretched. That 120-degree rotation, it's the real game changer. It forces you to think dynamically about anatomy in a way static diagrams just can't capture.
Okay, and just so everyone knows the scope here, we're going to cover a lot. Things like thyroid lobectomy, total thyroidectomy.
The cyst trunk procedure for those thyroglossal duct cysts, parathyroidectomy, subtotal parathyroidectomy.
Right, plus autotransplantation, cryopreservation, and that really complex area, central neck dissection, the CND.
Yep, we're hitting all the high-stakes procedures.
Okay, let's rewind right back to the beginning, the embryological blueprint, because as you said, this explains why thyroid tissue sometimes ends up in really weird places.
Exactly. It all starts incredibly early, around 31 days after fertilization. You get this little thickening, median endodermal thickening, right there in the floor of the primitive pharynx.
And then it starts to move.
Yeah, as the embryo develops and the heart descends into the chest, this thyroid precursor travels downwards. It stays connected for a while by this tube, the thyroglossal duct.
And that journey leaves a little mark in the adult mouth, right? A landmark.
It does, yeah. The foramen caecum, it's that little pit you can sometimes see or feel way at the back of the tongue.
Where exactly?
Right at the junction between the front 2/3 of the tongue, the part in your mouth, and the back 1/3, the pharyngeal part. That's the original starting point.
Now, things get a bit more complex with the C cells. The main thyroid tissue comes down the middle.
Mm-hmm.
But these calcitonin-secreting cells, the parafollicular cells, they join from the side.
Correct. They get incorporated through fusion. The developing thyroid bumps into and fuses with parts of what's called the caudal pharyngeal complex, specifically stuff from the fourth pharyngeal pouch and this thing called the ultimobranchial body.
Ah.
And that fusion brings in the C cells. They're crucial for calcium regulation, working alongside the parathyroids.
But this whole descent process, it doesn't always go perfectly, does it?
Mm-hmm.
That leads to these congenital anomalies. What if the descent just stops, fails completely?
Right. If it fails completely, you end up with a lingual thyroid. The thyroid tissue just stays put at the base of the tongue.
But it can stop anywhere along the path.
Exactly. You can get ectopic deposits, little bits of thyroid tissue sublingually, so under the tongue, prelaryngeally, in front of the larynx, or pretracheally, in front of the trachea. And this leads to a really, really critical surgical trap.
The trap being mistaking this tissue for just a regular cyst.
Precisely. If a surgeon finds a lump anywhere along this midline path of descent, they have to be super cautious. You can't just whip it out thinking it's a simple cyst.
Why not?
Because if you remove that lump and it turns out to be the patient's only functioning thyroid gland, well, you've just caused severe, lifelong hypothyroidism.
Ouch. So imaging is essential beforehand.
Absolutely mandatory. Ultrasound, maybe a radioactive iodine scan. You have to know if that's the only thyroid tissue the patient has before you even think about removing it.
Okay. And the most common leftover bit, the thyroglossal duct cyst. That needs the cyst trunk procedure. What's the key detail that makes that procedure work so well against recurrence?
The genius of the cyst trunk procedure is realizing that the duct often tunnels through the hyoid bone.
The bone in the neck, yeah.
Right. So to really stop it coming back, you have to remove the cyst itself, the tract, the duct, and the central part of the hyoid bone. All in one block, en bloc. Taking out that piece of bone gets rid of the microscopic duct remnants that hide in there and cause cysts or infections to come back later.
Got it. Then there's the pyramidal lobe, another remnant.
Yep, another remnant. It's from the very bottom part of the duct persisting. You see it in maybe 50% of people.
Where does it usually sit?
It typically extends upwards from the isthmus. The bit connecting the two lobes often slightly to the left, heading up towards the hyoid bone. Sometimes there's a fibrous band connecting it called the levator glandulae thyroideae.
And the surgical point here.
Crucial point. If you're doing a total thyroidectomy, you absolutely must look for and remove the entire pyramidal lobe. If you leave it behind, you're basically leaving a potentially large chunk of functioning thyroid tissue.
Okay. And what about these smaller remnants, the thyrothemic thyroid rests, or TTRs?
Ah, the TTRs. Yeah, these are little bits of midline tissue that can extend downwards, sometimes right into the ligament connecting the thyroid and the thymus.
How common are they?
They're found in over half of people. And they're tricky because during surgery, they look a lot like lymph nodes.
Yeah.
Or worse, they can be mistaken for ectopic parathyroid glands.
Leading to them being removed unnecessarily.
Exactly. You might take out what you think is a suspicious node or a bonus parathyroid, but it's just a harmless TTR.
Right. Now let's talk landmarks. The Zuckerkandl tubercle, the ZT. The sources call it an anatomical arrow. Why?
The ZT is this posterolateral bulge or projection off the thyroid lobe. It's there in maybe 70% of people. And it's super important because embryologically, it comes from the ultimobranchial body.
The same origin as the superior parathyroid glands.
Exactly. And because of that shared origin and its position, it acts like a signpost.
A signpost pointing to what?
Pointing towards the recurrent laryngeal nerve, the RLN. In over 80% of cases where the ZT is well developed, the RLN runs just posteromedial to it, deep to it.
So finding the ZT is often the first step in finding the nerve safely.
Often, yes. It gives you a really consistent landmark in a very tricky area. When that tubercle is big, the nerve can even look like it's running inside the thyroid gland as it dives deep towards the larynx.
And that shared origin explains why the superior parathyroids are usually found near the ZT too.
Precisely. It makes finding them a bit more predictable, gives the surgeon a good starting zone. But, when we look at how the parathyroids develop overall, there's a key difference between the top ones and the bottom ones.
Right. Parathyroid the third becomes the inferior glands, and the phi becomes the superior. Why does that order matter so much surgically?
It matters because parathyroid the third, which becomes the inferior glands, it migrates earlier and travels much further down than parathyroid the fourth, the superior one.
Ah, so that's why the inferior ones are harder to find.
That's exactly why. Their longer journey means their final position is far more variable. They can end up way down in the chest, inside the thymus, stuck to the outside of the thyroid capsule, whereas the superior glands, with their shorter trip, tend to stay put higher up, usually near that ZT. Much more predictable.
Okay, let's shift from embryology into the OR. Starting with the gland itself, what are the typical specs? Size, weight?
Sure. A normal thyroid is about 25 grams. Each lobe is maybe 5 centimeters long, 3 centimeters wide, and 2 centimeters thick, give or take.
And the isthmus, the connecting bit.
Usually quite small, sitting right over the second and third tracheal rings.
Before making any incision, the surgeon relies on surface landmarks, right? Suprasternal notch, cricoid cartilage.
Thyroid notch, hyoid bone, yeah. Those are your palpable guides.
But you mentioned distortion can be a problem even before you start cutting.
Oh, absolutely. If you have a patient with a very short, thick neck, or much more obviously, a massive goiter, those landmarks can become completely unreliable.
Oh, so?
Well, a huge goiter can push the trachea way off to one side, or the whole gland might sink down behind the sternum, becoming retrosternal.
Well,
You just can't feel the normal landmarks anymore.
so patient positioning is key. Usually neck extension.
Yep, some degree of neck extension helps bring the thyroid up and forward, makes it more accessible.
And the incision. There's been a shift away from the old rule of thumb.
That's right. The old 2 fingers above the suprasternal notch, it's just too variable depending on the patient's build.
So what's the better landmark now?
The sources really push for using the cricoid cartilage. Placing the incision, a nice, gently curving transverse one along the skin lines, about 1 to 2 centimeters below the cricoid cartilage.
Why is the cricoid better?
Because the cricoid's position relative to the thyroid isthmus is much more consistent, whether the patient has a long neck or a short neck. It gives you good access to both the top and bottom poles of the glands.
Makes sense. But the overriding principle is still
Exposure, exposure, exposure. The length of the incision has to be adequate to see everything clearly. You absolutely cannot compromise surgical safety finding the nerves, the parathyroids, just for a slightly smaller scar. Cosmetic concerns come second.
Okay, incision made. We're raising flaps now. What's the first potential hazard zone?
Right away, as you're developing those flaps in the subplatysmal plane, that's the layer just under the thin platysma muscle.
Which can be patchy in the middle.
Exactly. As you raise the flaps up towards the thyroid notch and down towards the sternum, the big risk is hitting the anterior jugular veins.
Why are they so problematic?
Their course is super variable. They run along the strap muscles, but they often have these bridging vessels connecting them across the midline, especially lower down if you nick one.
Bleeding. Lots of it.
Immediately. Messy bleeding that obscures the whole field right at the start. You basically have to stop everything and get control before you can even properly see the deeper layers.
Okay, veins controlled. Beneath the platysma, we hit the strap muscles, the inferioid group. They're wrapped in fascia, right?
Yep. Encased by the superficial layer of the deep cervical fascia. These are the muscles that pull the larynx down and stabilize it.
Let's map them out. Inner and outer pairs.
Okay, so the inner pair, closer to the trachea, are the thyrohyoid muscle superiorly and the sternothyroid inferiorly. The outer pair are the sternohyoid and the omohyoid.
And the standard surgical approach.
Ideally, you just separate them right down the midline fascia. That preserves them completely.
But sometimes, for really big glands or substernal ones, you have to cut them.
Yes, sometimes division is necessary for exposure, but how you cut them is critical because of their nerve supply.
Which comes from?
Almost all of them are supplied by the ansa cervicalis, which is formed by nerve roots C1, C2, and C3. The exception is the thyroid muscle that gets its supply from C1 fibers that travel along with the hypoglossal nerve.
So if you have to cut, where's the safe zone?
You cut high, at the level of the cricoid cartilage or even slightly above it. This preserves the main nerve supply coming down from the ansa cervicalis, which enters the muscles lower down.
And specifically dividing the sternothyroid muscle.
Dividing the sternothyroid high up, near its insertion, is the classic move to get better exposure of the superior pole of the thyroid. It gives you more room to work up top while saving most of the muscle function.
Okay, strap muscles retracted or divided. Now we're looking right at the thyroid gland itself. It has 2 capsules, right? An inner and an outer.
Correct. There's the outer false capsule, which is really part of the pretracheal fascial, the general fascial layer in that area.
Yeah.
It's pretty well developed on the front and sides.
But thin on the back.
Critically thin, yeah. And incomplete posteriorly. Then, right against the gland tissue, you have the inner true capsule. It's very adherent.
And where that outer false capsule thickens up medially, posteriorly, that's the ligament of Berry.
Exactly. The ligament of Berry, or LB, is this really tough fibrous thickening of the fascia. It acts like a suspensory ligament, anchoring the back of the thyroid lobe firmly to the cricoid cartilage and the top couple of tracheal rings.
And its importance.
It's hugely important because the recurrent laryngeal nerve runs extremely close to it, sometimes even seems to pass through it right before it enters the larynx. It's the final tricky point of dissection when removing the thyroid completely.
Okay, now let's place the parathyroids relative to these capsules. Their location dictates the whole preservation strategy.
Right. The superior parathyroid glands are usually pretty consistent. They tend to lie between the true and false thyroid capsules, tucked in that potential space.
But the inferior ones are the wanderers again.
Yep. reflecting their longer embryological journey. The inferior glands are much more variable. They might be intrathyroidal, actually inside the gland or between the capsules like the superiors, or sometimes they're just sitting loosely on the outer surface of the false capsule surrounded by fat.
Which is exactly why the capsular dissection technique is so fundamental. It's not about finding the parathyroids first.
No, it's about creating a plane to keep them safe. The idea is to peel the thyroid away from them.
How did that work? How do you peel?
You start the dissection high up on the surface of the true capsule, and then you bluntly push the false capsule, along with the fatty tissue around it, which contains the parathyroid's blood supply and often the gland itself. You push that layer off the thyroid, usually moving medially towards the trachea.
So you're basically mobilizing the parathyroids with their blood supply, lifting them away from the thyroid before you start ligating vessels.
That's the goal, exactly. You're trying to preserve that delicate vascular pedicle feeding the parathyroid.
And this technique then exposes the small vessels that actually go into the thyroid.
Yes. As you peel that layer off, you reveal the small terminal branches of the inferior thyroid artery that are diving into the true capsule. Those are the ones you need to meticulously ligate or clip, one by one.
Patience is key, sounds like.
Extreme patience, because if you rush and cause bleeding here, you immediately lose visibility of the parathyroids and, more importantly, the RLN, which is running nearby.
Okay, let's say the dissection is going well. How do you visually spot a normal parathyroid gland in amongst all the fat and other tissue?
Well, they're tiny, remember, only 15 to 40 milligrams, but they have a distinct look, usually a pale tan to a kind of dark reddish-brown color.
What else?
They often have a characteristic shape, sort of flattened, oblong, with really discrete rolled edges, and they're typically nestled in a small, defined pocket of yellowish fat, which helps them stand out.
Any other visual clues?
Yeah, under magnification, surgeons often look for these little light-refracting pinpoint specks peppered on the surface. It's quite distinctive.
Once you think you've found one, its position relative to the RLN is the key anatomical relationship. Let's map that out in 3D.
Okay, imagine the RLN as the main north-south axis in that posterior field. The superior parathyroid glands are usually found about a centimeter above the point where the RLN crosses the inferior thyroid artery.
And their position relative to the nerve itself.
They tend to be lateral to the nerve in the sagittal plane, further away from the midline, and posterior or dorsal to the nerve in the coronal plane, so kind of tucked behind and to the side of the nerve.
And the inferior glands, the variable ones.
They're usually found closer to the inferior pole of the thyroid, but their relationship to the nerve is flipped. They tend to be medial to the RLN's sagittal plane, closer to the trachea, and anterior or ventral to the RLN's coronal plane.
So in front of the nerve and closer to the midline, understanding that anterior-posterior medial-lateral difference is vital.
Absolutely vital. Especially if you're searching for a gland that hasn't been easily identified, you need to know where to look relative to the nerve.
Now, sometimes, despite the best efforts, a gland gets accidentally removed or its blood supply is compromised. That triggers parathyroid autotransplantation.
Right. If a normal parathyroid is taken out, or if you can clearly see its devascularized turn dark blue or black, and you confirm it's parathyroid tissue with a frozen section.
Frozen section being a quick microscopic check during surgery.
Exactly. If it's confirmed parathyroid and non-viable, immediate autotransplantation is the standard of care. The mantra is, you covet every single parathyroid gland. You cannot afford to lose them, or the patient risks permanent hypoparathyroidism.
Okay, so you decide to autotransplant. Where do you put it? Does it matter?
It matters hugely, and the choice depends on why you're doing the transplant.
Meaning?
If you've removed a normal gland from a patient who didn't have hyperparathyroidism, you typically mince the gland into tiny pieces and implant it into a nearby, easily accessible muscle with good blood supply. The sternocleidomastoid muscle in the neck is a common choice.
But if the patient does have hyperparathyroidism, and you're removing abnormal tissue but need to save some,
then you choose a site far away from the neck. The classic site is the brachioradialis muscle in the forearm.
why the forearm? Seems counterintuitive.
It's all about potential future problems. If the patient develops recurrent hyperparathyroidism from that transplanted tissue later on, it's much, much easier and safer to go back and operate on the forearm to remove it than it is to reoperate in a heavily scarred central neck, where the risks to the RLN are magnified.
Makes sense. Reduces future morbidity. And what about cryopreservation? saving tissue for later.
That's usually considered when you have an abundance of parathyroid tissue, which can happen in patients with secondary or tertiary hyperparathyroidism, often linked to kidney failure. If you've removed most of the glands but have extra healthy-looking tissue, you can freeze it.
That's backup.
Exactly. As a backup, in case the remnant tissue you left in the patient fails down the line, then you could potentially thaw and transplant the cryopreserved tissue later.
Okay, let's talk blood supply. The thyroid is incredibly vascular, isn't it? Something like 5.5 milliliters per gram per minute.
Yeah, it's got a huge blood flow. Makes sense given its metabolic role.
Two main arteries feed it. Let's start with the superior thyroid artery, the STA.
Right. The STA is usually the very first branch off the external carotid artery. Surgically, its big deal is its close relationship with the external branch of the superior laryngeal nerve, the EBSLN.
They run together.
They run very close, often parallel initially, with the artery usually just below the nerve. The STA supplies the upper half of the thyroid lobe and the isthmus, and sometimes it gives a branch to the superior parathyroid gland, too.
Okay. Now, the other major artery, the inferior thyroid artery, the ITA. This is where things get messy, anatomically speaking.
Absolutely. The ITA usually comes off the fibrocervical trunk, which is a branch of the subclavian artery, though maybe 15% of the time it comes directly off the subclavian itself.
And its path.
It comes up into the central neck, deep, running along the longest colon muscle behind the carotid sheath. It's the main supply to both the superior and inferior parathyroid glands, which is critical. Then it divides into branches near the thyroid.
And its relationship with the recurrent laryngeal nerve, the RLN, is notoriously variable. What patterns does the surgeon need to expect?
All of them. Seriously. The RLN can pass anterior to the ITA branches, it can pass posterior to them, or it can weave right between the branches of the artery. There's no single rule.
So you just have to find the nerve and see what it's doing relative to the artery in that specific patient.
Precisely. Sometimes gentle traction on the ITA painfully can help lift or define the nerve's path, making it easier to spot, but you absolutely cannot assume the relationship.
And then there's the wild card. The thyroidea artery. Rare, but dangerous.
Very dangerous if present. It's found in maybe up to 10% of people. It's an unpaired artery, usually arising low down from the aortic arch or the brachiocephalic trunk or maybe the right common carotid.
What makes it so hazardous?
Its location. It runs straight up the neck right in front of the trachea in the midline.
Ah, so if you're doing a thyroidectomy or especially a tracheostomy.
Exactly. If you don't recognize it and ligate it properly, injuring the thyroidea can cause absolutely catastrophic hemorrhage right in the operative field, potentially fatal.
Okay, let's switch to venous drainage. Superior, middle, and inferior thyroid veins draining this rich plexus. One of them is particularly notorious for bleeding early on.
That's the middle thyroid vein. It comes off the side, the lateral aspect of the gland, and drains directly, often as a short, stout vein, straight into the internal jugular vein.
And why is it such a hazard?
Because it's right there as you start mobilizing the gland laterally. The sources call it especially vulnerable to injury. It's often one of the very first vessels the surgeon deliberately looks for and ligates right after opening the neck fascia. Getting control of it early prevents troublesome bleeding that can really obscure the deeper, more critical structures like the RLN.
Right. Okay, now lymphatic drainage. This is key for understanding how thyroid cancer spreads and why we do central neck dissection, or C&D. Where does the lymph flow first?
Generally, the lymphatics follow the blood vessels and nerves. The initial drainage is primarily into the central compartment of the neck. That's designated as level 6 and also includes level 7 slightly lower down.
What nodes are in level 6?
Level 6 includes several groups. The prelaryngeal nodes, sometimes called Delphia nodes, right in front of the larynx, the pretracheal nodes, in front of the trachea, and crucially, the right and left paratracheal nodes.
And the paratracheal nodes are the tricky ones.
Yes, because they lie right along the tracheoesophageal groove, intimately associated with the recurrent laryngeal nerve on both sides. Dissecting them out is high risk for nerve injury. Level 7 is technically the anterior superior mediastinum, nodes down near the brachiocephalic vessels.
For the most common type, papillary thyroid cancer, PTC, is there a typical pattern of spread?
Generally, yes. It tends to be stepwise. First to the central neck nodes, level 6, then potentially to the lateral neck nodes on the same side, ipsilateral levels 2, 3, 4, and then maybe across to the other side, contralateral, lateral neck, or further down into level 7.
But there's an important exception. Skip metastases. What's that?
Skip mets occur when cancer cells seem to bypass the central compartment and show up first in the lateral neck nodes, even when the central nodes appear clean.
How often does that happen?
It's surprisingly common. The sources say it's observed in over 20% of PTC cases.
Any particular reason?
It seems to be more common when the primary cancer is located in the superior pole of the thyroid lobe. It implies there might be direct lymphatic channels draining the upper pole laterally, skipping level 6.
So surgically, you can't just assume the lateral neck is clear if the central neck seems okay.
Absolutely not. Especially with upper pole tumors, it complicates surgical planning significantly.
Okay, let's define the boundaries for that central neck dissection. The ATA American Thyroid Association has a definition for level 6. What are the borders?
Right. The ATA defines level 6 like a box. Superiorly, it's the hyoid bone. Inferiorly, the suprasternal notch. Posteriorly, the prevertebral fascia, the deep layer covering the spine muscles, and laterally, the medial border of the carotid sheath on each side.
And C&D means removing all the lymph nodes and fatty tissue within that box.
Within that level 6 box, yes, plus usually the level 7 nodes in the upper mediastinum. It's a thorough clean out of that whole central compartment.
It's really important to distinguish therapeutic versus prophylactic C&D. What's the difference?
Therapeutic CND means, there's cancer in those central neck nodes. Maybe you felt suspicious nodes or saw them on ultrasound or they were confirmed during surgery. You're removing known gross disease.
And prophylactic.
Prophylactic, or sometimes called elective CND, is when you remove the central neck nodes even though they look and feel normal. You do it in patients considered high risk for microscopic spread, trying to get ahead of the cancer before it becomes obvious.
But this procedure, C&D, it's not without significant risk, is it?
Definitely not. Because you're dissecting extensively right around the parathyroid glands and both recurrent laryngeal nerves, C&D carries a significantly increased risk of causing permanent hypoparathyroidism and/or RLN injury compared to just a thyroidectomy alone.
So it's a major trade-off, weighing the benefit of potentially better cancer control against the risk of serious complications.
Exactly. It's a very complex decision, often debated, and depends heavily on the specific patient, the tumor characteristics, and the surgeon's judgment.
Okay, we've arrived at arguably the most critical part, the nerves. If mastering this surgery hinges on one structure, it has to be the recurrent laryngeal nerve, the RLN.
Absolutely. The standard of care now is mandatory identification and visualization of the RLN during thyroidectomy. It's been proven time and again that finding and protecting the nerve significantly reduces the risk of accidentally injuring it.
And the consequences of injury are devastating.
Completely. Voice changes, breathing difficulties, problems swallowing. It can be a major disability.
Now, the RLN isn't the same on both sides. The anatomy's different, right versus left, because of how the big blood vessels develop in the chest. Let's start with the right RLN.
Okay. The right RLN comes off the vagus nerve higher up in the neck. It loops underneath the right subclavian artery, going from front to back. Because the subclavian is relatively high, the nerve starts its ascent back up into the neck earlier and takes a more oblique path.
Oblique.
Meaning it runs more laterally to medially, and often it's a bit more anteriorly placed compared to the left. It doesn't always sit neatly in that deep groove between the trachea and esophagus.
Okay, and the left RLN?
The left side goes much lower. It branches off the vagus deep in the chest, loops underneath the aortic arch specifically, just behind the ligamentum arteriosum, which is a remnant of a fetal blood vessel, and then it ascends almost vertically upwards.
So its path is more straightforward.
More vertical, yes. It tends to run more consistently within that tracheoesophageal TE groove, and it's typically located a bit more posteriorly, more deeply tucked away than the right RLN.
Ah, I see the implication for central neck dissection now. Dissecting around the right RLN sounds trickier because it's more exposed and oblique.
That's generally true. On the right side, the lymphatic tissue you need to remove often lies both in front of and behind the nerve's oblique path, so you're working on both sides of it. On the left, because the nerve is usually deeper in the groove, most of the lymphatic tissue tends to be anterior to it, making the dissection potentially a bit more straightforward relative to the nerve itself.
Now, Randolph described 3 main ways surgeons approach identifying the RLN. The lateral approach is the most common one now.
Yes, the lateral approach is standard for most cases. It involves retracting the thyroid lobe upwards and medially that 120-degree roll we talked about.
Uh-huh.
And you combine that with the capsular dissection technique. You typically find the nerve around the middle part of the lobe, often near where it crosses the inferior thyroid artery, and ideally situated between the superior and inferior parathyroid glands once they're identified.
What's the main advantage of this lateral approach?
The big advantage is that it usually requires dissecting out only a relatively short segment of the RLN. And crucially, because you're already doing that capsular dissection, it naturally facilitates preserving the blood supply to the parathyroids as you're peeling them off the gland.
Okay. What about the inferior approach? It's listed as least common.
Yeah, the inferior approach is usually reserved for really difficult situations, maybe dense scarring from previous surgery, or a massive goiter that distorts everything down low. You find the nerve way down at the thoracic inlet, near where it enters the neck.
Disadvantages.
The main downside is it requires a much more extensive dissection of the nerve over a longer course, which inherently increases the risk of injury. Plus, you're working right near the inferior parathyroid glands, putting them at higher risk, too.
And the third way, the superior approach.
Here, you identify the RLN right up high, near where it actually enters the larynx, underneath the cricothyroid muscle. This entry point is anatomically the most consistent location for the nerve.
When would you use this?
It might be best for reoperative surgery where the lower neck is a mess of scar tissue, or maybe for huge substernal goitres where you can't find the nerve lower down.
But it has its own risks.
Definitely. You're working right in that dangerous ligament of Berry area, so there's a higher risk of bleeding that's hard to control. You also risk injuring the EBSLN, the other important nerve we'll get to, and potentially the superior parathyroid gland.
Let's zoom in on that ligament of Berry, the RLN danger zone. You said the nerve's exposed for maybe its last 2 centimeters here, but this is where most injuries happen. Why is this short stretch so perilous?
It's perilous because the nerve is really tethered here, tightly bound by fascia, and the anatomy is very constricted right before it dives into the larynx. It's covered by 2 fascial layers, the looser superficial vascular layer containing tiny blood vessels, and then a deeper, really tough fibrous layer, which is the true ligament of Berry.
And the nerve often takes a sharp turn.
Yes. Just before it enters the larynx, the RLN often makes a little bend, sometimes called a knee or genu. This fixed point, this genu, is probably the single most common spot for injury because it's easily stretched, crushed, or inadvertently clipped during the final dissection if the surgeon isn't incredibly careful.
And there's a specific vessel here with a rather dramatic nickname, the vessel of regret.
Ah, yes. That usually refers to the inferior laryngeal artery, which is a tiny terminal branch of the ITA. It often runs just posterior to the RLN, right at the ligament.
Why, a vessel of regret?
Because if you accidentally injure it, it bleeds. And because it's behind the nerve, the bleeding end tends to retract deep into the space behind the RLN. Trying to stop that bleeding, putting a clamp or cautery back there, carries a huge risk of grabbing or burning the nerve itself. It puts the surgeon in a terrible spot.
This final dissection at the ligament forces a big decision, doesn't it? Total versus near total thyroidectomy.
It really does. The surgeon has to weigh the benefit of removing that last tiny scrap of thyroid tissue, which is plastered onto the nerve entry point, against the very real risk of causing permanent nerve damage by dissecting it off.
So sometimes leaving a sliver behind is the safer option.
Often, yes. Many experienced surgeons will opt for a near-total thyroidectomy, deliberately leaving a tiny fleck of tissue right at the nerve insertion point to prioritize voice preservation over getting out every last microscopic cell.
What about the RLN branching? Does the nerve sometimes split before it enters the larynx?
It does. True extralaryngeal branching, where the nerve splits into motor branches outside the larynx, happens in maybe 30% of people. Usually occurs along that final 1 to 2 centimeter stretch near the ligament of Berry.
And the implication?
You have to identify and preserve all the branches. A major pitfall is seeing what looks like a small branch and mistaking it for something insignificant, like maybe the non-recurrent laryngeal nerve, which we'll discuss, and then dividing it, only to realize later you cut a major motor branch.
Yikes. And what if the nerve trunk you find looks unusually skinny?
That's another red flag. If the main trunk looks thinner than expected, you must dissect backwards, proximally towards the ITA. You need to make absolutely sure that you haven't mistaken a smaller anterior branch for the main trunk, leaving a larger, functionally important posterior branch behind that you might then injure.
Okay, let's talk about that anatomical variant, the non-recurrent laryngeal nerve, or NRLN. It's rare.
Very rare, especially on the left. On the right side, it occurs in about 0.5% to 1.0% of individuals. On the left, it's exceedingly rare, maybe 0.04%, and it's always associated with cetus in versus complete reversal of the internal organs.
What actually causes an NRLN? Why doesn't it loop down?
It's an embryological thing. It happens when the fourth laryngeal arch on the right side gets absorbed abnormally during development.
Yeah.
And importantly, it's almost always associated with a specific abnormality of the aorta and its branches called arteriolussoria.
Arteriosuria. That's the key sign to look for.
That is the absolute key preoperative sign. Arteriolussoria means the right subclavian artery arises abnormally as the last branch off the aortic arch instead of the first, and then it has to cross behind the esophagus and trachea to get over to the right arm.
So if you see arteriolussoria on imaging,
Oh.
you must anticipate an NRLN on the right side. The nerve won't loop under the subclavian because the subclavian is in the wrong place. Instead, the nerve will come directly off the vagus, high in the neck, posterior to the carotid, and travel straight medially towards the larynx.
If you're not expecting it.
You'll cut it. Almost guaranteed. It looks like just another small vessel or fascial band crossing the field horizontally. Preoperative imaging and awareness are crucial here.
Okay, one more nerve. The superior laryngeal nerve, SLN, specifically its external branch, the EBSLN. This affects voice quality, right? Pitch control.
Exactly. The SLN comes off the vagus nerve high up around the C2 level. About 1.5 centimeters below its origin, near the hyoid bone, it splits into two branches.
The internal branch, which is sensory, provides sensation to the upper larynx and base of the tongue. And the external motor branch, the EBSLN,
And the EBSLN does what?
it travels down, usually running anterior to the superior thyroid artery, and it innervates just one muscle, the cricothyroid muscle.
Why is the cricothyroid muscle important for voice?
The cricothyroid muscle tenses the vocal cord. It's responsible for changing pitch, particularly for hitting high notes.
So EBSLN injury.
Injury causes cricothyroid paralysis. The patient might still have a voice, but it'll often sound weak, breathy, monotonous. They lose that upper range and vocal projection. For a singer, teacher, public speaker, it can be a career-ending injury.
How do surgeons protect the EBSLN? It sounds vulnerable near the top of the thyroid.
Protection really comes down to meticulous dissection of the superior pole vessels. The key is individual ligation. You carefully identify and tie off or clip each small branch of the superior thyroid artery and vein right at the surface of the thyroid capsule, one by one.
As opposed
As opposed to just putting a big clamp across the entire vascular pedicle at the superior pole and tying it off en masse. That kind of mass ligation dramatically increases the risk of accidentally catching the EBSLN in the tie, especially if it runs close to the gland.
There's a classification system, the Cernia classification, that describes how close the nerve runs to the pole, right? Which types are highest risk?
Yes, Cernia classifies the relationship. Type 1 is safest. The nerve crosses the vessels more than 1 centimeter above the top edge of the thyroid pole. Types 2A and 2B are the high-risk ones.
What's the difference between 2A and 2B?
In type 2A, the nerve crosses less than 1 centimeter above the pole. Still very close. But in type 2B, the nerve actually crosses below the very top edge of the thyroid pole, sometimes running right across the anterior surface of the gland before diving into the cricothyroid muscle.
So the gland itself is hiding the nerve in type 2B.
Exactly. It's the most treacherous configuration.
And does the risk change depending on the size of the gland?
Dramatically. For a normal-sized thyroid, maybe 18–20% of patients have a type 2B nerve. But if the patient have a large goiter that stretches everything upwards, that high-risk type 2B pattern jumps to over 50%, maybe even 54%, according to some sources.
Wow. So with large goiters, you almost have to assume the nerve is in danger during superior pole dissection.
You absolutely do. It forces a much more cautious, nerve-centric approach to taking down the superior pole.
Okay, let's tackle some specific procedural challenges. First up, the substernal goiter. When the thyroid grows down into the chest, that sounds incredibly difficult.
It definitely adds complexity. The main issue is that the gland gets wedged into the rigid thoracic inlet, often causing significant compression of the trachea right at that bottleneck.
Can it still be removed through the neck incision?
Surprisingly, yes. The vast majority, probably around 95%, can be removed entirely through a standard cervical incision.
You get the chest part out. Sounds like you can't see down there.
You often can't, not directly. It usually requires blind, blunt finger dissection. The surgeon uses their finger to carefully work down behind the sternum, gently teasing and delivering the substernal portion of the gland up into the neck wound.
Blind dissection sounds risky. What's the main danger?
The RLN is at much higher risk during this maneuver. It can get stretched, splayed out over the surface of the goiter, or even densely stuck to it. You often can't reliably identify the nerve until after you've delivered the substernal component up into the neck.
The sources warn strongly against morcellation here, breaking the gland up.
Absolutely. Trying to remove a substernal goiter piecemeal is extremely hazardous. You risk massive, uncontrollable bleeding deep in the chest, potentially spreading cancer cells if malignancy is present, and almost certainly leaving behind residual thyroid tissue down low.
So it has to come out intact if possible. What about needing to open the chest doing a sternotomy?
That's rarely needed. It's usually reserved for very specific, complex situations, maybe a true dumbbell goiter with a narrow neck connecting a small cervical part to a huge substernal part, or sometimes for difficult, reoperative substernal goiters where scarring is intense.
And if you do have to do a partial sternotomy, is there a unique complication risk?
Yes, the main risk specific to the sternal split approach is injuring the pleura, the lining of the lung, specifically the cupola, the very top part which extends up into the base of the neck. A tear there can cause a pneumothorax, a collapsed lung.
Okay, shifting gears to parathyroidectomy. For conditions like secondary hyperparathyroidism, where all four glands might be enlarged for gland disease, the operation is often a subtotal parathyroidectomy. What exactly are you aiming to leave behind?
The goal in a subtotal parathyroidectomy is very precise. You remove 3.5 glands, essentially. You leave behind approximately 1/2 of the most normal-looking gland, or about 50 milligrams of viable parathyroid tissue.
Why that specific amount?
It's a balance. You need to leave enough tissue to prevent permanent hypoparathyroidism, but not so much that the hyperparathyroidism persists or quickly recurs. 50 milligrams is generally considered the sweet spot.
If the surgeon has a choice of which half gland to leave, is there a preference? The sources mention favoring inferior glands.
Yes, there's a subtle preference. If you have multiple glands that look suitable for leaving a remnant, the inferior parathyroid glands are often chosen.
Why?
Because, as we discussed, the inferior glands tend to lie anterior to the recurrent laryngeal nerve. If the patient unfortunately develops recurrent disease in that remnant later and needs another operation, reoperating anterior to the RLN plane is generally considered safer for the nerve than having to dissect posteriorly where the superior glands usually reside.
Smart. Planning ahead for potential reoperation.
Ah.
Okay, now the real nightmare scenario. Bilateral neck exploration for missing glands. You can't find one or more parathyroids. What's the systematic search strategy, especially if an inferior gland is missing?
Right. This requires a methodical, exhaustive search. You start where they should be. Careful inspection, palpation all around the posterior and lateral aspects of the thyroid capsule, checking near the ZT for superiors, lower pole for inferiors.
So you're not there?
Next logical step is to explore inferiorly. You gently mobilize and remove the fatty tissue in the paratracheal areas, and then you carefully deliver the thymus gland up into the neck wound.
Why the thymus?
Because the inferior parathyroids often descend with the thymus during development and can end up embedded within it, sometimes quite deep in the thymic tissue extending into the chest.
Still no luck after checking the thymus.
Then you have to broaden the search systematically into less common ectopic locations. You explore the potential spaces around the esophagus and pharynx, parapharyngeal, retropharyngeal, paraesophageal, retroesophageal, carefully dissecting both in front of and behind the plane of the RLN. Sometimes a missing gland is found right up near the nerve's entry point into the larynx.
What are the last resorts before giving up and maybe planning a sternotomy later?
A few final maneuvers might be tried. You could open the carotid sheath, as glands occasionally hide there. Or, controversially, some might consider ligating the inferior thyroid artery on that side, hoping to infarct an unseen gland. Or, perhaps more commonly as a last resort, performing a thyroid lobectomy on that side, just in case the missing gland is truly embedded within the thyroid tissue itself, intrathyroidal.
Wow, it really is an exhaustive search. Okay, let's try to synthesize all this meticulous detail. What are the absolute key surgical principles and hazards to summarize?
Number 1, without a doubt, hemostasis. Bleeding is the enemy. Even minor oozing obscures the nerves and parathyroids, turning a precise dissection into a dangerous guessing game. Meticulous control of every small vessel is mandatory.
Number 2.
Energy devices. Be incredibly cautious. Unipolar or bipolar electrocautery, harmonic scalpels, vessel sealers, they all generate heat or electrical current. They should not be used close to the RLNs or the parathyroid glands due to the risk of thermal injury or current spread causing damage. Careful clipping or tying is often safer right near these structures.
And the cardinal rule for nerve safety.
The unidentified tissue rule. cannot emphasize this enough. No tissue that might be the RLN should ever be clamped, cut, cauterized, clipped, sealed, or divided until the nerve has been definitively 100% identified and visually confirmed. If in doubt, dissect more.
What about staging the procedure if things go wrong, say during a planned total thyroidectomy?
Yes, crucial principle. If you're planning a total thyroidectomy, standard practice is to operate on the more diseased or suspicious lobe first. If, on that first side, you suspect or confirm an RLN injury, maybe through nerve monitoring, or visually, you should generally terminate the procedure at that point.
And leave the second lobe for another day.
Exactly. You defer the completion thyroidectomy to a later date, usually several months later, once you know the status of the first nerve. This prevents the potentially catastrophic outcome of causing a bilateral RLN injury, which can lead to permanent voice loss and the need for a tracheostomy.
One final nuance. Using frozen section for parathyroid identification. What's the limitation?
Frozen section is incredibly useful to confirm if a piece of tissue is or is not parathyroid, but that's usually all it can reliably tell you intraoperatively.
It can't distinguish benign from malignant or adenoma from hyperplasia?
Not reliably, no. The subtle cellular features needed to distinguish, say, a parathyroid adenoma, a single benign tumor, from hyperplasia, multiple enlarged glands, are often obscured by the freezing process. So the surgeon shouldn't rely on the frozen section result to decide how much parathyroid tissue to remove, for example, just 1 gland versus 3.5 glands. It confirms identity, not necessarily the underlying pathology guiding the extent of reception.
We've covered an immense amount of ground from that tiny speck in the embryonic pharynx all the way to the microdissection around the ligament of Berry. We've hit vascular variants like arteriolysuria, nerve hazards like the Cernia type 2B EBSLN. It truly highlights the complexity.
It really does. And it brings us back to Halstead's quote. True mastery isn't just knowing the textbook map. It's being able to navigate that map dynamically in real time while the landscape itself is being distorted by pathology and surgical retraction. It's that constant millimeter-level judgment call between clearing disease and preserving critical function, calcium balance, voice, breathing.
Which leads perfectly to our final thought for you, the listener, something to think about. We spent a lot of time on the capsular dissection, meticulously preserving the parathyroid glands and their blood supply, which comes mainly from the inferior thyroid artery. But we also established that the ITA's relationship with the recurrent laryngeal nerve is incredibly variable. The nerve can be in front, behind, or between the artery's branches. So here's attention. How often does the absolute necessity of protecting the blood supply into the light-sustaining parathyroid glands inadvertently force the surgeon to manipulate or work closer to the voice-preserving nerve than they'd ideally like?
It's that fundamental conflict, isn't it? Protecting one vital structure potentially puts another at risk. It requires constant vigilance and calculation.
A core surgical dilemma in this intricate space. Thank you for joining us on this deep dive. We'll see you next time.